Disease of cardiovascular system, where we'll be discussing about cardiac failure, congenital heart disease, Fallot's tetralogy, infective endocarditis, arteriosclerosis, ischemic heart disease. Starting with cardiac failure. Cardiac failure, or otherwise known as heart failure, it is usually defined as a pathophysiological state in which usually we find that there is impaired cardiac failure which is unable to maintain an adequate circulation for metabolic needs of the tissues of the body. So because there's cardiac failure and the blood cannot be pumped sufficient, or blood is not being pumped to the entire other body parts, there's a compromised body functioning systems which occur, and this is known as cardiac failure. So based on the onset, that is, it could be of rapid onset, then it is known as acute cardiac failure. Suppose it's of a delayed onset or otherwise gradual in onset, then it is known as a chronic cardiac failure. So usually the chronic forms, that is a severe forms of cardiac failure, usually they end up into congestive heart failure, which where we see this condition, that is excess of fluid accumulation in the tissues as well as in the blood vessels. This results in congestive heart failure, and this is a end result of usually chronic cardiac failure conditions. And coming to the etiology, usually it could be of three probable reasons: intrinsic pump failure, or otherwise in cases when there's increased workload in the heart. This workload could be, it might either increase the pressure load, or otherwise it can increase the volume load. That is a blood volume load, which on the heart it tries to in turn increase the pressure. It could also be because of impaired filling of the cardiac chambers. So intrinsic pump failure, it is usually seen in ischemic heart disease as well as certain cardiomyopathies, whereas increased pressure load because of an increased workout in heart, usually we see in certain conditions like any excessive exercise conditions, or otherwise any arterial hypertension or valvular disease are seen. In such type of condition, we see that there's increased pressure load. Coming to increased volume load, usually we see in conditions such as severe anemia, thyrotoxicosis like condition, that is where there's increase in the thyroid hormone produced, which has an effect on the heart. So these are certain conditions where there's increased workload on the heart, which could be either because of the pressure load or otherwise because of the volume load. Coming to the impaired functioning of the cardiac chambers, it is usually seen in cardiac tamponade as well as in constructive pericarditis. So these are certain etiological factors which can cause cardiac failure, or otherwise known as heart failure. Coming to the types of heart failure, based on the onset, as already described, there could be acute or chronic, and based on the side of the heart involved, whether if it is a right side involvement or otherwise left side involvement, it is known as right-sided heart failure or left-sided heart failure, and based on the flow of the blood flow, it is known as forward or backward failure. So these are certain types of heart failure. Coming to acute and chronic heart failure, usually they are usually being classified based on the onset. That is acute heart failure usually occurs when there's rapid in onset, and in certain conditions where there's myocardial ischemia or otherwise certain bacterial toxemia or otherwise viral myocarditis, all these cardiac tamponade, these are the conditions which can result in acute heart failure, that is which are rapid in onset. Usually we see in acute heart failure there is sudden reduction in the cardiac output. This sudden reduction in the cardiac output will cause an overload on the myocardium. And finally in acute heart failure, coming to the distinguishing feature between an acute heart failure and a cardiac heart failure by certain investigations is that we do not find any edema in case of acute heart failure, whereas in chronic heart failure we find a definite presence of edema. This is because in chronic heart failure, since to compensate this chronic heart failure, since it is a slowly occurring heart failure and finally causing the degradation slowly, this could result probably into certain compensatory mechanisms, and these compensatory mechanisms usually cause they adapt to certain conditions such as cardiac hypertrophy or otherwise cardiac dilatation, because of which there will be excess accumulation of fluid, and this will result in formation of edema. So these are the differentiating features between an acute heart failure and a chronic heart failure. So usually the chronic heart failure occurs in conditions mostly when there is a long-standing pulmonary infections or otherwise multivalvular ruptures are certain conditions where we see, and most commonly it is because acute heart failure turning into a chronic heart failure. So this is what, and it is an acute heart failure and chronic heart failure. Left-sided heart failure and right-sided heart failure. It is usually, though heart is an whole organ which can be affected, but rather from the clinical point of view, it is important to know which part of the heart is being affected, and based on that, it has been broadly classified into left-sided heart failure as well as right-sided heart failure. Coming to left-sided heart failure, it is usually occurs when there is any upstream, that is fluid upstream has been reduced, resulting in failure of this left-sided part of the heart to function properly. And based on that, it results in accumulation of the fluid upstream into the lungs. Usually we see the major causes in such case of left-sided heart failure is an ischemic heart disease, as well as in certain condition of certain cardiomyopathies. We can see a left-sided heart failure. Other than that, we can also see in arterial hypertension. Coming to the pathological changes, based on these conditions, this left-sided heart failure usually results into pulmonary congestion and edema. This pulmonary congestion and edema, in turn, it will result in dyspnea and orthopnea. That is, it results in difficulty in breathing, since it is a condition which is occurring in which is occurring in the lungs. It results in difficulty in breathing, resulting in dyspnea and orthopnea. And other than that, the other pathological condition which results because of this left-sided heart failure is decreased left ventricular output. This decreased left ventricular output usually results in hypoperfusion as well as in hypoxia, that is decrease in the oxygen content which is being supplied to the different organs through the blood. So this is what happens in left-sided heart failure. Coming to the right-sided heart failure, it is not necessary that it occurs because of the primary causes that have a target on right heart failure, but rather it is because mostly because of a consequences occurring to left-sided heart failure. So coming to the major causes which we see in right-sided heart failure, it is because of cor pulmonar, and otherwise because of pulmonary valvular disease, or otherwise any hypertension occurring in the pulmonary system can result in right-sided heart failure. And coming to the pathologic changes which occur in right-sided heart failure, it is we see the systemic venous congestion, that is there's a blood supply which is being we see that it is being there's congestion in this blood supply, and mostly we see organs affected are lungs, kidney, liver, and it might also result in ascites. It might also cause this venous congestion in neck veins also. Other than that, we see reduced cardiac output, that is the complete cardiac output is only being reduced. And so in right-sided heart failure, usually we see this is because this results in a reduced cardiac output, unlike that in the left-sided heart failure. Coming to the next type of heart failure, it is the backward heart failure as well as a forward heart failure. In forward heart failure, we see that there is failure of the blood being pumped from the heart, and this will result, since there is reduction or otherwise complete failure of blood to be pumped from the heart, this results in complete diminished blood supply to the other parts of the body organ systems, since there is reduced or otherwise failure in the pumping system of the heart. And this reduced blood flow, it is also results in reduced diminished renal perfusion, that is to the kidneys, this perfusion is being reduced. Then this results in activation of the renin-angiotensin aldosterone system, which is a system which in turn helps in maintaining, or it is a kind of compensatory mechanisms which tries to adapt to this reduced blood flow and tries to compensate with certain other mechanisms such as tachycardia and by increasing the cardiac output. So this is what we see in forward heart failure. Coming to the backward heart failure, we see that either of the ventricles, it could be any of the ventricles, which would fail to eject the blood normally. So it's not necessarily because of from the heart as in the forward heart failure. In the forward heart failure, we have seen that there's complete failure or otherwise reduction in the blood flow from the heart. But rather we see here in the backward flow, we see that the heart has shown its complete functions, proper adequate functions, but rather it is based on the ventricles, that is any ventricular or valvular diseases can result in this backward heart failure, and it will usually result in rise in the end diastolic volume, that is diastolic volume, it begins to increase or elevated in condition. Then it can also increase in volume as well as pressure in the atrium, because it's in effect occurring because of any defect occurring in the ventricles. There is a increase in the volume and pressure as well as in the atrium, since it's from the ventricular system. And then other than that, this in turn, this increase in the volume and pressure in the atrium in turn consequently causes an elevated pressure in the veins. So this is what occurs in a backward heart failure. Coming to the pathophysiological compensatory mechanisms in a cardiac failure, usually we see when there's either left ventricular heart failure or right ventricular heart failure, there are certain compensatory mechanisms which our body tries to adapt to those conditions. And among them, one of them is activation of the norepinephrine the atrial natriuretic peptide. So norepinephrine, it is a hormone which is being or said to be a polypeptide which is being released from the body to which has an effect on the heart. And other than that, atrial natriuretic peptide, it is a polypeptide which has a vasodilatory effect. So both of them, when they function together, they usually in conditions where there is decreased cardiac output or any improper blood supply, then there is activation of this norepinephrine atrial natriuretic peptide. This in turn will cause tachycardia, that is, it increases the blood pressure. When there is increase in the blood pressure, it means there is increased output or increased blood circulation being happening. And this increased blood circulation will in turn cause an effect, or it will stress the myocardium, because there is increased blood being circulated, or increased blood being oxygenated and further being sent to the heart. Because of this, there will be increased stress occurring in the myocardium. This increased stress on the myocardium will result in congestive heart failure, because congestion itself means excess accumulation of fluid within the tissues or the blood. So this results in congestive heart failure. So this is one of the compensatory mechanisms adapted during right ventricular heart failure, or otherwise left ventricular heart failure. Coming to the second compensatory mechanism being adapted by right ventricular heart failure, otherwise left ventricular heart failure, is there will be activation of the renin-angiotensin aldosterone mechanism, which is usually carried out in the kidney as well as in the liver. So since kidney is also associated with the absorption of the sodium and water, and even in pumping of sodium ions, because of this activation of the renin-angiotensin mechanism, which actually is a means for this sodium and water retention system to be maintained in the kidney. So this starts showing its effect in the sodium as well as on the water retention system. And this in turn, because of this excess of fluid, that is congestion, it further causes its effect on the myocardium. So there's further stress on the myocardium, and this results in this also could result in congestive heart failure. So coming to the next compensatory mechanism that is being adapted is myocardial contractility. That is, since myocardium is being made up of a muscle tissue, that is cardiac muscle tissue, and it contains sarcomere. So during this compensatory mechanism, there is myocardial contractility. That is, the myocardium seems to contract because of its functional activity, since it is being made up of a muscle. And this myocardial contractility is based on individual muscle fiber known as sarcomere. Because of this contraction being occurring on an individual muscular unit known as sarcomere, this in turn causes cardiac workload. That is, there will be increased workload. Since it is being contracted as such, there will be increased workload, and this workload is being compensated with self-stretching. That is, it starts stretching. Once it's been contracted, then it starts stretching, which is a normal physiological function of a muscle, contraction and relaxation. Because of this cell stretching, it will result in compensatory hypertrophy, or otherwise known as dilation. That is, it means the cardiac system, it seems to expand in size. Hypertrophy is an increase in the size of any organ or any tissue, and this results in dilatation, that is excess of fluid accumulation within that organ or tissue. So this is what happens in one of the compensatory mechanism when there is left ventricular heart failure, otherwise known as right ventricular heart failure. So there is a picture showing the difference between the normal heart and the heart with dilated cardiomyopathy. So heart with dilated cardiomyopathy is known as centric dilation, whereas that without dilation of the cardiomyopathy is known as eccentric dilation. So we see that in the picture as it shows, the muscles fibers, they have stretched, and the heart chambers also in turn enlarged. We see the difference between the normal heart and the heart with dilated cardiomyopathy, that there is increase in the stretching of the left ventricle, which in turn causes the contraction of the right ventricles. We see that there is a decrease in the right ventricle as well as increase in the size of the left ventricles. This is what happens in dilated cardiomyopathy. So coming to the signs and symptoms of heart diseases, usually we say that since heart has its major effect on the lungs, because the blood is being sent for purification or oxygenation, so a patient usually starts because of pulmonary hypertension or any pulmonary vascular disease, valvular disease. This in turn causes coughing, that is patient might have severe coughing in such cases. Other than that, we see there's pleural effusion, that is, which means when there's excess of fluid around the lungs, where we see in congestive heart failure also, there's pleural effusion in such kind of conditions. Other than that, we also see ascites is seen. Ascites, as already described, this is one of the compensatory mechanism which is being maintained when there's a right-sided heart failure. So we see there's swelling in the abdomen and it results in ascites. Then other than that, we also see there's tiredness, muscular weakness because of hypoperfusion as well as hypoxia. There's muscular weaknesses which can be seen, and this results in tiredness of the patient. And we have seen in conditions such as in left-sided heart failure, there is the pulmonary changes which are associated with left-sided heart failure results in shortness of breath. That is, it could be because it might result in dyspnea or otherwise in orthopnea. And coming to the next condition affecting the lung is pulmonary edema. That is excess of fluid being accumulated in the lungs. This is known as pulmonary edema. This usually occurs in cases of right-sided heart failure, we see. Next coming is the pumping action of the heart grows weaker. Since there's increase in the fluid accumulation as a part of the compensatory mechanism for the right or otherwise the left-sided ventricular failure, this can result in excess accumulation, that is, it might result in congestion, and this condition in turn causes a pumping action of the heart, making it to be more weaker. That is, it causes more stress in the myocardium and it results in weakening of the myocardium. So these are certain signs and symptoms of heart failure. Coming to the congenital heart disease, usually we find congenital itself means by birth. That is, there is a heart disease which occurs by birth. That is, any abnormality of the heart which is present from the birth is known as congenital heart disease. And usually it is most commonly seen, highly prevalent in case of premature infants. That is, babies which are born abnormally. They could be any physically handicapped or mentally handicapped babies. So they are known as premature infants, and most commonly this congenital heart disease is being affected in premature infants. So premature infants, amongst the premature infants we find congenital heart disease being most prevalent, and after premature infants it is up to only 0.5% which occurs in newborn babies. It could also be because of a multifactorial inheritance, that is because of the genetic influences or otherwise environmental influences. Genetic influences means it is being carried from parents to the offspring. That is, the child might develop because of any abnormalities in the genetic system, and which results in congenital heart disease. Otherwise, it could also be environmental. Environmentally, it could be because of certain microorganisms such as rubella. Rubella is an infection which is carried from mother to the offspring. When the mother is being carrying, that is when the mother is pregnant with a fetus in her stomach, then when the mother takes drugs which are certain drugs for any form of any kind of medication, or otherwise the mother is heavy alcoholic or otherwise any smoking induced habits, this might cause an effect on the fetus and result in congenital heart disease of the fetus. So any infection from rubella and patient taking medication for that disease can also cause a direct effect of the fetal heart, and this results in congenital heart disease. So coming to the classification of congenital heart disease, usually the first and foremost it is being classified into three basic parts. That is a malposition of the heart. The heart only itself could be malposition, that is in an abnormal position, or otherwise it could be because of the shunts, or otherwise it could be because of the obstructions. Among the shunts, it can be further classified into left to right shunts or otherwise right to left shunts. Among the left to right shunts, it is a ventricular septal defect, atrial septal defect, and patent ductus arteriosus. These are certain shunts which occur from left to right shunt, and they, since they do not show any cyanotic changes immediately, they are known as acyanotic. And since these disease can also show further in a progressing disease, they can show cyanosis changes, so they are known as late cyanotic group. Coming to the group of right to left shunts, they are known as cyanotic group because they immediately show the signs and symptoms of cyanosis. And amongst them, it is the phallic tetralogy, or otherwise the transpositioning of the greater arteries, and persistent truncus arteriosus, and then comes the tricuspid atresia as well as tricuspid stenosis. So these are the features which we see when there's right to left shunts present. Coming to the obstruction part, that is, it is also known as obstructive congenital heart disease. Since it is because of the obstruction, it is termed as obstructive, and since it is seen in a child by birth, it is known as congenital heart disease. And amongst them, it is because of the coarctation of the aorta, or otherwise because of aortic stenosis or aortic atresia, or otherwise because of pulmonary stenosis or pulmonary atresia. So there is a classification for congenital heart disease. Coming to the malpositions of the heart, malpositions of the heart, usually we find there could be malpositions of the heart, that is the position of the heart is in an abnormal place other than that of the normal. So one of them, among them, we see dextrocardia is seen. Dextrocardia means that is the apex of the heart, it points towards the right side, that is the right side chest, and this is known as dextrocardia. This dextrocardia can occur associated with the situs inversus. Situs inversus is a condition which means based on the position of the positioning of this heart in case of dextrocardia, there is also positioning of the other organs according to that of the position of the heart, that is a pointing of the heart apex towards the right side of the chest. So this appears to be normal when dextrocardia occurs in association with situs inversus. But later stages we see this dextrocardia can also be isolated. When this is isolated, we see in cases of this isolation, that is abnormal positioning of the heart, that is apex of the heart pointing towards the right side, could be alone, which should not be associated with other organs and tissue malpositioning. Rather, it could be associated with other abnormalities of the myocardium, that is the transposition of the arteries or otherwise the ventricles. So this is what is isolated dextrocardia and dextrocardia. So coming to the normal heart anatomy with that of the dextrocardia, that is the transposition of the arteries, this is what we see. Usually we see in the aorta there is systemic circulation. Amongst this systemic circulation, it is the oxygenated blood which is being carried out. But we see that in transpositioning of the arteries, greater arteries, that is in dextrocardia, that the systemic circulation, it carries deoxygenated blood. Similarly, we also see that in cases of this pulmonary artery also, we find usually it is a deoxygenated blood which is supposed to be carried, but whereas in dextropositioning, that is dextrocardia, we see that this pulmonary artery carries an oxygenated blood. Similarly, there is even circulation of blood also varies because of this transposition or the malposition of the heart. So this is what the picture explains, that is the blood flow being quietly or vice versa to that of the normal blood flow. Coming to the shunts which is known as which result in cyanosis. So they are the left to right shunts which might result in acyanotic, otherwise late cyanotic group. Among that, most commonly we see when there is a shunt from left to right, it means there is a shunting of the blood, that is circulation of the blood or pumping of the blood from left to the right side. Because of this pumping of the blood from left to the right side, there is quite overload being increased on the right side, and this overload will in turn cause pulmonary hypertension, that is increase in the blood pressure within the lungs, and this pulmonary hypertension in turn causes right ventricular hypertrophy, that is the right side ventricle seems to enlarge in size, and this enlargement in size and since it carries an much of the poorly oxygenated blood. Since it carries a much of oxygenated blood itself, then this might not result in acyanosis, that is, it might not result in cyanosis. Rather, it can result in late cyanotic heart disease, that is, if the blood is being more of poorly oxygenated, it might result in cyanosis. But since the blood is being shunt, that is, there is movement of blood from left to right itself, so it is an oxygenated blood, it does not result in cyanosis. So it is known as acyanotic, otherwise late cyanotic group. So amongst that, we see certain defects, that is a ventricular septal defect, which constitute 30% of all the congenital defects, and this congenital defect is further based on the situation where we see this defect. Usually, if it is more than 90%, it is up to 90% of these cases of with ventricular septal defect, they show this defect on the membranous septum, which is very close to the bundle of his fibers. Next, coming to that, that is 10% of the others. They show either in the subpulmonic area, that is just below the pulmonary artery ventricle, or otherwise below the aorta, that is known as subaortical. Otherwise, they might be present in multiple defects, that is within the muscular septum. They might be present anywhere within the muscular septum. So this what is the ventricular septal defect. Coming to the atrial septal defect, that it is a defect which is seen either in the fossa ovalis or otherwise also known as ostium secundum type, and it is seen in 90% of cases that this defect is present in fossa ovalis, and 5% we see that it is present in the ostium premium type, and another 5% we see in sinus venosus type. So these are the atrial septal defect. Coming to patent ductus arteriosus, which is present in 10% of all the congenital heart disease, and usually this patent ductus arteriosus, it is a connection which is being created between the aorta as well as the dividing or bifurcating pulmonary artery, which is usually not in any connection which is usually seen in a normal heart, but since it is a heart disease, we see that this abnormal connection being created between the aorta as well as the area of the bifurcation of the pulmonary artery. Usually, if suppose this type of condition is being seen in any newly formed neonatal condition, then this usually closes at the first or at the second day of the birth of the child. But if suppose this connection is being established and still persistent even after 3 months of the birth of the child, then this is known as an abnormality. This could be said as a congenital heart disease, and it is seen as an isolated defect in 90% of the cases with patent ductus arteriosus. But whereas in 10% of the cases where we see patent ductus arteriosus is this disease is not alone, but rather it is being associated with the ventral septal defect as well as the coarctation, that is a connection between the aorta, and otherwise associated with pulmonary stenosis or aortic stenosis. So these are certain defects which we see from a left to right shunt. So there is a picture which shows a normal heart on the left side and then heart with ventricular septal defect. Because of this ventricular septal defect, that is because of a connection being created between the arteries and the ventricles and the aorta as well. This could result in mixing of the blood from the left side as well as from the right side, because of which that will result in a mixing of the oxygenated blood, that is the purified blood, and the deoxygenated or unpurified blood. So ventricular septal defect, which can be observed, which can be seen between the dividing pulmonary artery as well as between the aorta. Coming to the atrial septal defect, there is a picture showing the atrial septal defect where we see that the blood is being pumped from the left atricle to the right atrium. And coming to the patent ductus arteriosus, we see that there is a duct which is being created between the aorta and as well as the pulmonary artery. Coming to the right to left shunt, which is also known as cyanotic group, amongst this we see that in this case we see that there is pumping of blood from the right atrium to the left shunt. Rather than a purified blood being pumped, it is a deoxygenated blood, and this deoxygenated blood results in cyanosis, so it is known as cyanotic blood. And the features which we see of this right to left shunt is seen in Pathology of Fallet, which contributes to 10% of all the congenital heart disease. And amongst this tetralogy of Fallot, we can further divide this group into cyanotic tetralogy and acyanotic tetralogy. So this group is being divided based on the pulmonary stenosis as well as on the size of the ventricular septal defect. So in cyanotic tetralogy, usually we see that the pulmonary stenosis is greater as well as the ventricular septal defect is mild. So because of this, there's pulmonary hypertension which can be seen on the right side, as well as on the acyanotic tetralogy also we see pulmonary hypertension on the right side of the atrium and the ventricle, and this condition is seen in the acyanotic tetralogy. Usually we see that the ventricular septal defect is rather unlike that of the cyanotic, but it is larger and the pulmonary stenosis is mild. So this is what we see in the defects in the cyanotic tetralogy and the acyanotic tetralogy. So this can also affect the tricuspid valve, which we see which shows an effect on the heart, as well as in the aortic orifice also. This changes in the orifice of the aorta also because of this tetralogy of Fallot. So there is a picture showing the features of tetralogy, differentiating feature between the normal heart and heart with tetralogy of Fallot, where we see that there is increased outflow from the aorta in case of tetralogy of Fallot. Other than that, we also see obstruction, which is a partial obstruction, that is which means stenosis of the right ventricular outflow to the lungs and then to the pulmonary valve. And other than that, we also see there's presence of ventricular septal defect, which is a major cause of most of the congenital heart disease. And there's also thickening of the right ventricle, which is known as hypertrophy. So these are the changes what we see in features of Fallot's tetralogy. Coming to the transposition of the greater arteries, among them it is the regular transposition and the corrected transposition. So the transposition itself means that is there's change in the position of the arteries amongst the greater arteries. So the regular transposition is that we see since among such cases like dextrocardia, we see that since aorta is placed towards the right side, that is the apex of the heart being placed pointing towards the right side of the chest. Among such cases, we see that the aorta starts arising from the right side, whereas the ventricles, they start arising from the pulmonary trunk, it starts arising from the left side. So this is what we see in regular transpositioning of the greater arteries. So from this aorta, the greater arteries usually start emerge from this aorta, that is from the right side. Whereas in corrected transposition, we see similarly that from the aorta, that is there's complete transposition of the great arteries, that is they emerge from the aorta and they start they draining into the right side. Whereas when we see that in case of corrected transposition of the great arteries, usually we find that there's malformations. In malformations, we see there's any transposition. It could be either of the aorta, otherwise the pulmonary trunk, or otherwise the atria in relation to the ventricles. So we see any abnormal positioning of these major structures within the heart occurring, then this is known as transpositioning. So this transpositioning, it is characterized by two features, that is a regular transposition and the corrected transposition. Within the regular transposition, we see that normally an aorta is placed posteriorly and towards the left side to the pulmonary trunk, but whereas we see in regular transposition that this aorta, it is placed anteriorly and to right for the pulmonary trunk. Because of this placement of the aorta, the great veins, they emerge from this aorta, from this aorta, and then finally reach the right ventricle. So this is what we see in regular transposition, and because of this we see that there is cyanosis of the patient, and mostly it is seen in children immediately after the birth. But in corrected transposition, we see that the aorta, they are usually aorta when they emerge from the right ventricle, and because of this the greater veins also emerge from the right ventricle, and then they pierce that into the they emerge from the aorta. This great veins, they emerge from the aorta, they enter the right ventricle, whereas the pulmonary part, they enter the left ventricle. Whereas we see in cases of transposition of the great veins, these pulmonary veins instead they emerge and then drain into the usually they drain into the left ventricle. But here in such conditions, we see that the pulmonary veins, they drain into the right ventricle, and the system systemic veins drain into the left ventricle, because of which there is cyanosis because of the production of deoxygenated blood, which is also a condition which is seen in complete transposition. So this is the transposition of great arteries. So coming to next is persistent truncus arteriosus. In such condition in like persistent truncus arteriosus, we see that the arch which usually separates the aorta from the pulmonary artery, usually it fails to develop, because of which it results in a single large common vessel. So the arch which separates the aorta as well as the pulmonary artery has been failed to develop, which results in a common vessel. And this common vessel, it is usually not single, but it is associated with other congenital disorders such as ventricular septal defect, and with this results in left to right shunt, and because of which cyanosis develops, and the prognosis is usually poor among such cases. And this is seen in children, usually gradually developing children with such congenital heart diseases. And usually in cases of tricuspid atresia and stenosis, we see in case of tricuspid atresia that there is absence of this tricuspid orifice. Because of the absence of tricuspid orifice, we see there is a dimple. Instead of this orifice, there is just a dimple or a kind of depression which is seen in the floor of the right atrium. So this is what is seen in tricuspid atresia. Whereas in tricuspid stenosis, we see that the tricuspid valve or the tricuspid cusps, they are usually smaller and they are malformed, that is they are abnormally formed, because of which also it can result in a alteration in the shunt, that is from a right to left shunt, because of which cyanosis develops, and these patients usually die soon after the birth, and they develop as cyanotic babies itself. So this is what is persistent truncus arteriosus and tricuspid atresia, tricuspid stenosis. So there is a picture showing the truncus arteriosus where we see usually because of the malformed structures in case of tricuspid arteriosus, because instead of a proper tricuspid valve being formed, there is only a depression, because of which there is change in the blood flow from left to right to left side. So there is a truncus arteriosus on the left side and tricuspid atresia showing the intrinsic tricuspid valve, that is thinning of the valve can be seen. Coming to the obstructive congenital heart disease, this is majorly because of the obstruction in the flow, because of the abnormally formed or otherwise constructions of the aorta, which can result in obstruction or the hampered flow of the blood circulation, which results in obstructive congenital heart disease. Amongst them, that is coarctation of the aorta. Coarctation itself means construction or narrowing of the aorta. So this is based on the positioning of the construction. So this construction that is compressing of the aorta, it could be that is below the duct or otherwise otherwise proximal to the duct. When it is just distal to the duct of the aorta, then it is known as postductal or otherwise adult type, and otherwise when it is seen proximal to the duct, that is superficial to the duct, then it is known as preductal or otherwise infantile type. So this is what we see in obstructive congenital heart disease. So here is a picture showing the coarctation of the aorta, that is the aorta, it is being constricted. Because of this coarctation of the aorta, the above and below that of the aorta, that is a superficial to the coarctation, and distal to the distal or posteriorly to the coarctation, we see there is bulging or otherwise known as hypertrophy of the aorta, that is increase in the size of the aorta. Because of this increase in the size of the aorta, there is hypertension usually seen. So in cases of postductal coarctation of the aorta, otherwise known as adult type of the aorta, we see that there is hypertension in the upper part of the body or superficial part of the body, and there is hypotension whereas in the lower part of the body. And because of this, we see that the patient shows symptoms of claudication as well as coldness of the extremities. Whereas in preductal or otherwise known as infantile coarctation of the aorta, we see that there is a superficial that is the upper part of the body starts showing the cyanosis, whereas since the lower part is being supplied with the normal blood, there is no cyanotic conditions which is seen in the lower part of the body. So there is a picture showing the coarctation of the aorta, and it is in the higher magnification view in the superficial text box. Coming to the aortic stenosis and atresia and pulmonary stenosis and pulmonary atresia. So these conditions which are being seen associated with other conditions, usually they do not occur primarily, but usually they are associated with other conditions. Aortic stenosis and aortic atresia, usually they show three types of morphological features. One is a valvular stenosis, that is the aortic valve. It usually shows abnormality, that is because of the malformed cusps can be seen in such case of aortic stenosis, or otherwise known as valvular stenosis. Whereas in the subvalvular stenosis, we see that there is a thick fibrous ring which is formed just below the aortic valve. This is known as subvalvular stenosis. Coming to the supravalvular stenosis, this means that supra means above, that is above the aortic valve there is thick fibrous ring which is being formed. Because of this formation, it results in obstruction in the flow, so it is considered as an obstructive congenital heart disease. Coming to the pulmonary stenosis and pulmonary atresia, usually we find in pulmonary stenosis, that is the cusps, that is the pulmonary cusps or the valves, they try to fuse with each other, and this fusion of this cusp result in a formation of diaphragm-like functioning, diaphragm-like feature is being formed. Because of this diaphragm-like formation, this results in the obstruction of the flow of the blood. So this is also considered as obstructive congenital disorder. Coming to the pulmonary atresia, usually we find that usually there is a communication between the pulmonary artery and the lung, but normally in a normal patient, but usually we find in congenitally obstructions or congenital diseases that there is no such communication formed between the pulmonary artery and lung, and this this lack of communication between the pulmonary artery and the lung is known as pulmonary atresia. So there is a picture showing the aortic stenosis, where we see that the cusps which are being malformed and resulting in obstruction in the flow of the blood. Then next coming is the differentiation between the normal heart and the pulmonary valve stenosis, where we see that because of the fusion of the cusps, they form a diaphragm-like formation and result in a diaphragm-like structure. This structure causes the obstruction of the flow of the blood.